your slide yet?
Can I share my screen?
Please do.
We will test the slide for Dr. Sofian first.
Yeah, please go ahead.
Please
Have
test.
you given me permission to share screen?
You already have permission. Please just go ahead.
One second.
You can share. We will start a webinar after you test your slides. So you open it.
I'm trying to, but I can't seem to see the share screen. Ah, there it is. Yeah.
Yeah, in the center.
Yeah.
We did not see your slide yet.
Hold on. Just 1 second.
Yeah. It's coming.
Okay.
Okay.
Can you see?
Yeah, I can see it. Next one, please. Forward period. Okay, I confirm your slides.
Okay, good.
Okay, Mr. Chairman is ready. Now I'm going to start recording.
Okay.
And share.
Okay.
Okay, please stop sharing,
So,
and we would like to display some annotation.
Okay. 1 second. Okay.
Okay.
Okay. Okay, we'll start recording. Okay.
Yeah, start. You may start now.
Okay. Hello everyone. I'm Dr. Zhongxian Lin from Kaohsiung, Taiwan. Welcome all of you to participate APSC Cloud Forum of Cardiovascular Disease Series webinar. Today, our topic will be a prediction of prevention and the prevention of cardiovascular disease and the cardiovascular event Asia Pacific update. Today, we will have 6 speech, just focus on our today's title. Next slide, please. So, about this, today's symposium, I think early prediction and the early prevention strategy is very important for daily practice. And in today's webinar, we will explore the paradigm of polypill therapy in cardiovascular disease and the event control, current hypertension control strategy, in whom with or without comorbidity, contemporary lifestyle modification by modern diet formula and exercise protocol, attractive GLP-1 and or GIP receptor agonist therapy for medical obesity management, as well as the understanding of global disease burden in Asia Pacific women. Upstream management is the most strategy effective approach in prevention of incidence and the cardiovascular in all cardiovascular event. Next slide, please. So I'm happy to be the chairperson for this webinar. Next slide, please. And first, I will introduce the first speaker, Dr. Sofian Johar from Brunei. Currently, Professor Johar is the head of the electrophysiology, Ripley's Hospital, and the Grand Girls JPMC at Brunei. So today, he will give a talk entitled Varioscope 2 for Prediction of Cardiovascular Disease and the Cardiovascular Event in Asia Pacific, a comparison with PCE and the PREVENT. Dr. Johar, please.
Thank you very much. I'm just going to share my screen. Can I check if it's visible?
Yep. Yes, okay.
Okay, great. So thank you very much for APSC for allowing me to discuss this. So my role today is to discuss score 2, which is in CVD risk prediction score for the prediction of cardiovascular disease and cardiovascular events in Asia Pacific, and compare against 2 existing scores, the pool cohort equation and PREVENT from America, basically AHA, ACC. So we know that over 80% of cardiovascular disease mortality occurs in developing countries, where premature deaths from heart attack and stroke were higher amongst those age under 60 compared to developed countries. So there's a real need to try and tackle this by addressing prevention and try and reduce this burden. So normally the approach is to look at, in the primary prevention cohort, i.e. those who have not had disease, to try and use various scoring systems to see whether they have an elevated cardiovascular disease risk. We have many, the original ones being the Framingham Risk Score. We have charts from WHO, the latest one, 2019. We have the pool cohort equations from 2013 from AHA, and recently updated the PREVENT equations 2023 to address some of the criticisms. And of course, from the Europeans, we have SCORE, and more recently SCORE 2, which is an iteration of the original SCORE. And this has been widely used in the European countries. But although it's been used increasingly in Asian countries, there are issues with which risk region we should fall into in Asia. And that was the purpose of SCORE 2 Asia Pacific project, which we'll discuss later. So one of the issues with trying to translate an existing risk score over to Asia is that these scores are derived from the local population, and when applying it to other areas, they have to be checked and validated. So basically, if you look at some of the data from the pool cohort equation, it performs okay, but there's still issues with some discrimination with the scores. If you look at this one from Taiwan as well, actually it performs okay, the pool cohort equation. But if you look at the area under the curve for the pool equation in males, is 0.68 and 0.61 in females. So okay, but obviously not so good, and with the discrimination considered modest, although the calibration was reasonable in patients without prior cardiovascular disease. So this is a nice review published recently with one of the co-authors from the SCORE 2 Asia Pacific. Essentially, this review looked at the implications for the AHA risk scores in the Asian population in America, as a lot of the Asians in America originate from East Asia. And this is a nice review looking at these various comparisons amongst the various scores. But essentially, there are lots of scores. Discrimination tends to be fairly modest to good. And it is still unclear as to which one we should be using in the region. This is another study from Malaysia looking at how good the scores are, the various scores are in the Malaysian population. Again, you can see here that they tend to classify patients very widely into low, intermediate, and high risk, highlighting that actually there's quite a lot of difference in terms of the at-risk population, depending on which score you look at. In this particular study, almost all models overestimated 10-year risk, either score to high-risk region, pool cohort equation, WHO score, and Framingham risk score. So again, the performance could be improved. So basically, what we looked at was trying to recalibrate score 2 with the European score for Asia Pacific in an attempt to see whether this would be a good approach to address cardiovascular risk prediction in the region. Of course, trying to recalibrate this for the whole of Asia Pacific is a challenging area with very, very widely differing incidence of cardiovascular disease across the region. But we took a similar approach to SCORE 2, which is the European study, European model development, European score. So they actually took 680,000 individuals and 30,000 events and recalibrated this in 4 different risk regions. And they validated in 25 cohorts in about 1.1 million individuals. The C statistics tended to vary from 0.67 to 0.81. And the idea being here that it would estimate the 10-year risk of fatal, non-fatal CVD. If you remember the original SCORE algorithm, they did not include non-fatal MI, non-fatal stroke, which is an issue because most events nowadays tend to be non-fatal MI and stroke. This would have an issue in predicting these non-fatal outcomes. And you can see here that they adopted the approach of classifying risk regions depending on their baseline cardiovascular risk into low risk to very high risk. And you can see here the 10-year risk varies a lot depending which region you come in, even if the risk factors are the same. So if you can see here, this is the map of the low risk to very high risk regions. You can see here that the high risk regions, very high risk regions, tend to correlate to countries which have low GDP per capita. This is traditional risk scoring approach, and they divided them up into two groups, less than 50 and 50-69, and classified their risk accordingly, green being low risk and red being high risk. And these are the charts for the low cardiovascular.
Hello.
Yeah.
I think he got disconnected.
The net interrupt.
Yeah, his voice, we lost his voice. His slides is still there. We lost him. I don't know.
We
I
lost
think he
it.
got disconnected.
Yeah, disconnected. So
we just wait for
for
one
one
moment.
few minutes, few seconds, and he's back. He's back. He's back. He's reconnecting again. Okay. Hello.
Hello.
Sorry, we just lost you. Yeah, please.
Sorry
please.
about that.
No problem. Please carry on. Please carry on. Okay. Yeah, please.
So to use scores derived elsewhere, external validation is required. So we did this project in collaboration with the original Score 2 group and with all collaborators from Asia and together with the Asian Pacific Society of Cardiology and the ASEAN Federation of Cardiology. So we took a similar approach in terms of looking at risk regions, and we divided up Asia Pacific area into low, moderate, high risk, and very high risk regions according to the most recently available age and sex standardized CVD mortality rates from WHO. You can see here that a lot of Asia falls into the moderate and very high risk and very high risk regions, and only a few countries fall into low risk regions. So the target population, as per Score 2, are individuals without cardiovascular disease or diabetes in Asia Pacific, 40 to 70 years. So we used the original Score 2 coefficients, so there's no new model derivation, and we did do an compared Score 2 coefficients Asian-derived models, and we did systematic recalibration using nationally representative incidence and risk factor data. So we externally validated it with over 9 million individuals from 13 prospective studies with 350,000 events. And the summary is that the pool C index across the studies was 0.7. It varies from 0.677 to 0.744. And it seemed comparable across risk regions and in males versus females. And again, if you look at the chart, like in Score 2, the risks vary widely depending on whether you come from a low risk region or very high risk region. So it's kind of gives you a flavor for the cardiovascular risk you can get in different countries, even with the same risk factors. So if you look at the coefficients, in general, in blue is the Score 2 original coefficient. If you look at the coefficients for age, smoke, BP, cholesterol, HDL, they tend to be quite similar. There are a few outliers, yes, but on average, they're quite similar to the European SCORE2 coefficients. And if you look at the cohorts in the low risk, moderate risk, and we combine here high and very high risk together, the C statistics overall is 0.7 and was quite reasonable across the groups. Looking at the recalibration cohorts is just to give you an idea of which cohorts this was derived from. So this was from South Korea, Singapore, Thailand, Brunei, and China. Unfortunately, we did not have any data from very high risk regions. So this is somewhat of an issue, but nonetheless, we managed to get enough patients for in the low risk and moderate risk groups. So looking at the individual cohorts, you can see here a wide spread with an average C statistic across the cohorts of 0.71. And if you look at males, it's 0.694 and females 0.694 again. So essentially, the discrimination was quite good in both males and females. However, when you compare it against WHO 2019, actually, although the difference in C index between WHO and the SCORE2 Asia Pacific recalibrated is actually not very different, which is not surprising considering that they are based on the same risk factors. If you look at the calibration, you can see here that in the Singapore group on the left-hand side, actually observe risk match predicted risk quite closely. The Thailand study in the middle moderate risk region, it's okay, but in the Korean group on the right, you can see here that the predicted 10-year risks seem to be higher than the observed risks, suggesting a bit of over-prediction of risk in this low-risk cohort. If you look at the comparison between WHO and SCORE2 Asia Pacific, you can see here some subtle differences in the performance of in the calibration of the scores compared to between WHO and Asia Pacific. In the Brugham's data for data from Brunei on the bottom left, you can see here some issues here with the calibration. Brunei is classified as a high-risk region, and actually the curves fit better if we do this in the we treat Brunei as a moderate risk region. And if we compare SCORE2 Asia Pacific versus SCORE2, you can see here that I think overall in blue is the Asia Pacific and in red is the European score. In SCORE2 performs better in some groups versus the recalibrated score in some groups. So despite trying to attempt to recalibrate for the various risk reasons for Asia Pacific, there is still in the different cohorts some perhaps issues with the calibration, but nonetheless, this is the best data that we have for Asia Pacific. So so basically adopting a similar approach to SCORE2, we've come up with some risk charts. And you can see here that we've chosen not to separate the whole cohort into two age groups and instead come up with a chart encompassing the whole age range. You can see here that we've classified patients into different categories of risk, 5%, 5 to 10%, 10 to 20, 20 to 30, more than 30. We do not say exactly which threshold should be used to decide on preventative therapy, but you can see here that that the risks vary widely again depending on which risk region you fall into. So, for example, in a low risk region, in a female with this risk factor, you get a 10-year risk of 5.7%. In a very high risk, you get 21.8%. And you can see here overall, compared to it's a similar determination of risk from SCORE2, the risks are overall quite a bit higher. So to summarize that part, like SCORE2, there are no age-related risk thresholds, and there's no recommendations at which level of treatment should be initiated. And there's a related editorial to the score highlighting that the real value of the score lies in the high-risk Asia-Pacific countries, which generally don't have much data that we can be used for generation of their own scores. So I would like to thank all the SCORE 2 Asia Pacific collaborators, with which none of this would be possible. And to conclude, SCORE 2 Asia Pacific can be used for prediction of 10-year CVD risk. Systematic recalibration enables use of existing risk models adjusted to target population, and we know that this is something very important to try and address the CVD epidemic in the region. The model is available as risk chart calculator, and the full data is available online. To summarize, I would say that no score is perfect. This is the best attempt that we could do to actually recalibrate SCORE 2 for the Asia Pacific region. The HA prevent equations have not been formally evaluated in a large-scale study as yet, as far as we can see. I'm sure that work is ongoing, and we can see how the prevent performs in the Asia Pacific in the future. And we hope that at least efforts will continue to try and improve scores and check their calibration in other populations. We hope this will act as a spur for people to clinicians everywhere to try and tackle the problem early and target populations at risk for cardiovascular disease. Thank you very much.
Okay, thank you, Dr. Johas. Excellent talk. We have 5 minutes for discussion. Is any question from the panel or from our speaker?
May I have one question, please?
Yes, please.
Yeah, that was a fantastic talk and very useful for us. SCORE 2 has got now two also subcategories, is one for OP for older people and one for diabetes. So do you have any, did you look into those two subcategories as well?
Yeah, actually, when we looked at this, there was a lot of debate about this, and it was interesting as to why diabetes was excluded initially from the original SCORE 2 development. We may not be able to go to the reasons here anyway, but nonetheless, that is a valid point. In terms of that, we restrict because we wanted to do this in something which was well characterized. We decided to and we weren't sure exactly as to how much effort would be required. We just elected simply to study this population as a first step. We agree that there are very many modifications of SCORE 2 to look at older people, to look at renal disease, etc. But that is work is still ongoing.
Thank you.
Okay. Any other question?
Yes, Dr. Sumkiat from Thailand. May I ask about the difference between the rural area or the urban area? We use the SCORE 2.
That's right.
Yeah.
I think this is actually a very good point. We know that the baseline prevalence and incidence of cardiovascular disease varies between urban and rural areas, which we unfortunately did not really able to look at in great detail, because by its very nature, we took a country-specific approach. This criticism has been applied to the data from China, for example, which is primarily the cherry cohort. The Thai cohort actually relies primarily on a rural population. So again, for Thailand, that could be a potential criticism of the score, but you can see it performs quite well, to be honest, if you take that as a representative group for Thailand. But yes, we take the point. That's subject of further work.
Yeah. And how about the smoking or waist circumference and the difference between Asian Pacific or in the European America? Because usually they use the BMI, but usually in Asia, we try to use the waist circumference or the waist height ratio, waist hip ratio, rather.
Yeah, this was not in the score, actually. We were restricted to what data was available from the available cohorts. And for simplicity, we, in order to recalibrate the score, we just use whatever the Europeans used in their own score.
Right. Okay. Thank you.
Okay. For more of any question from the panel? So if no more questions, thank you for Dr. Johar's talk. I know you were good to go to the other meeting. Thank you very much.
Thank you.
So next, I will introduce our second speaker, Dr. Soumitra Ray from India. Dr. Ray currently is the Vice President of Cardiological Society of India, and also ex-professor in VV Canada Institute of Medical Science, and a consultant at Woodland Hospital, Kolkata, India. Today, Dr. Ray will give a talk entitled Integration of Fixed Dose Combination Therapy, Polypill Therapy in Prevention of Cardiovascular Disease and the Cardiovascular Event, a South Asia Point of View. Dr. Ray, please.
Thank you, Dr. Lin. Very good morning, and thank you, APSC organization, for inviting me to and giving me the privilege to share my thoughts with you. As Dr. Lin has already said, the subject is contemporary. It's not so new, but it is still very relevant. Integration of fixed dose combination therapy, that is polypill, in prevention of cardiovascular disease and cardiovascular event, particularly focusing on our part of the world. Let me say that. Now, we know that main preventable causes of death all over the world, as it is done long time ago by World Health Organization, that if we tackle 6 causes, those are the main culprits. That's cholesterol, obesity, physical inactivity, sugar, tobacco, and raised blood pressure. So we know if we can control these few risk factors, we can prevent a lot of cardiovascular disease. And the world map of cardiovascular disease, if projected in 2050, you will see that the crude mortality burden is anticipated to be 91.2% from 2025 to 2050, also almost doubling, amount to 24 million deaths across Asia by the year 2050. And South Asia will likely experience the increase in crude cardiovascular mortality around 85%. And you know that Interspire study of 4,548 adults with coronary heart disease from 14 countries across 6 WHO regions found what is the appalling condition of our preventive measures. 91% did not attend cardiac rehab, 61% BP is not controlled, 83% cholesterol is not controlled, 87% sugar not controlled, 41% are obese, 67% are not doing exercise as per norm, and 13% are still smoking. So you can imagine how far we have to go to have a proper preventive measure about coronary heart disease. And you know that multiple comorbidities increase the cardiovascular risk by 4 to 7 times. If we have hypertension, dyslipidemia, and diabetes, and if we see their concurrence rate, 65% will have, say take an example of a hypertensive patient. 2/3 of them have got dyslipidemia, about 16% have diabetes, almost half of them are obese. And we know that hypertension plus other cardiovascular disease risk factor is a common patient phenotype worldwide, particularly in Southeast Asia and Asia Pacific region, which is the seat of metabolic syndrome, that is obesity, dyslipidemia, dysglycemia, so on. But we also know that multiple risk factors on total cardiovascular disease in the Interheart study showed that hypertension alone, the risk, and if you have got 3 more risk factors with hypertension, there is a 20-fold increased risk of having cardiovascular disease. So we know the importance of tackling multiple risk factors together, which was endorsed by Framingham Heart Study in 2006, almost 2 decades ago, which showed that as the number of risk factors increases, the adjusted cumulative cardiovascular incidence increases very rapidly. STENO-2 trial, though it is an old trial of 2008, actually hit the nail on the head and concluded that in at-risk patient with type 2 diabetes, intensive intervention with multiple drug combination and behavior modification had sustained beneficial effect with respect to vascular complication and on rates of death from any cause and from cardiovascular cause. Just 2 slides on these. Intensive therapy versus conventional therapy can much more significantly control your sugar, cholesterol, triglyceride, and the blood pressure, which is reflected into the event reduction of intensive therapy versus conventional therapy. If you see, you don't have to go by the figure, you just see the difference of the columns when you are tackling all the risk factors aggressively versus when you are approaching the problem casually. So what a benefit you can achieve. On this background came the polypill by World and Law 2003, the BMJ article. And actually they said that please preserve the article, this volume of BMJ, which will give you dividend 20 years down the road. You will be proud that you are possessing this volume of BMJ where the polypill concept was launched. That was the editorial comment. What was this polypill? Put all the drugs into one pill, use the low dose, target multiple risk factors at a time, consequently reduce the overall risk, let the pill be used by anyone aged 50 and over, consequently reduce the risk for anyone and prevent the majority of cardiovascular events. So it's a kind of blanket treatment, which very fastidious people say, oh no, this is a blanket people, it is not patient tailored, it is not tailored therapy, but we will come why it is important. It is a simplification of treatment of polypill, a strategy to reduce cardiovascular disease by more than 80%. And the earlier you start this therapy, the years you gain in life will be much more impressive. Say, if you start below 65, you will gain 24 years. If you start at 85, you will gain 14 years of life. There are 3 basic fundamental premises on which it works. Comprehensive risk reduction, irrespective of specific risk factor level. That is very important. I am not measuring the pressure, sugar, cholesterol. I am treating them blanketly by something. Improved compliance, because your 1 tablet you are taking a day, and improved cost effectiveness, because that will be subject to debate and come to that. Now you see why compliance is so important. Young adults with antihypertensive, 2/3 are non-adherent. And if you are non-adherent, your cardiovascular disease risk increases by 60%. So what is the rationale for the pill? Improved adherence, as I said, because of simplifying the regime. Cost effectiveness effectively reduces cost. Prevention, primary prevention, it is much more important. It may not be so good in secondary prevention when you have to go for more targeted risk factor control. And global burden of cardiovascular disease can be very efficiently addressed by this polypill approach. And here is an analysis when all reported benefits from trials are added up to this, a maximum reduction of 80%. You see, if you continue give LDL cholesterol with statin, pressure with 2 or 3 classes of drug, homocysteine with folic acid, blanket. You don't have to check homocysteine. Give folic acid 5 milligram daily. Platelet function, just these 4 components, 80% risk reduction. And that's how the concept is evolving of single pill combination from 2001 till today. If you see the bottom line, there is primary prevention trial, secondary prevention trial, HOPE trial, 6,300 patients, reduces MES and median follow-up of 5.5 years. Polyiron, 6,800 patients, reduces MES versus only lifestyle. TIPS trial, TIPS 3, 5,700 patients, reduces MES. Secure trial, everything showed they reduce the MES very significantly. What drug should we combine? Statin is a must. Then the antihypertensive. It can be a RAS blockade with a thiazide or a thiazide-like diuretic, or with a calcium blocker or beta blocker, with or without aspirin. So polyiron study aimed to study the effectiveness and safety of a cardiovascular polypill containing aspirin, atorvastatin, hydrochlorothiazide, enalapril or valsartan for primary or secondary prevention of cardiovascular disease. And what they found, if you see on the right, many of the parameters have got p-value 0.05. Fetal ischemic heart disease, non-fetal ischemic heart disease, non-fetal and fetal stroke, non-cardiovascular disease, and everything. Then came the very phenomenal study from Interheart by Salim Yusuf. You know, he's the phenomenon in polypill market. In 2020, it came in New England Journal. 5,700 high Interheart risk score patient given polypill. What is that? Simvastatin 40 with atenolol 100, hydrochlorothiazide 25, and ramipril 10, plus minus aspirin. There is some significant reduction of systolic blood pressure, reduction on heart rate, reduction on LDL cholesterol, which translates into first event of the primary outcome reduced by 21%, and first and recurrent events was reduced by 24%. Both were clinically significant. If you add aspirin to this, placebo versus aspirin, you get a non-significant difference of primary outcome, and cancer outcome is also not very significant. But if you add the aspirin to this cardiovascular polypill, you accrue extra benefit. You see the green line when you are giving the aspirin with the polypill, I mean including the aspirin into the polypill, and you are getting some extra benefit both in fast and recurrent events. Then came another study by Joseph et al. Published in Lancet 21, fixed dose combination of, it is a meta-analysis of HOPE-3, TIPS-3, and polyiron, 18,000 odd patients when LDL is reduced very significantly and also systolic blood pressure, which causes a significant reduction of the primary endpoint of cardiovascular death, heart attack, stroke, and revascularization. You can see the curves and the p-value of 0.0001. And with aspirin, without aspirin. With aspirin, the curve is more significant, but even without aspirin, the rightmost curve is again very significant. So with or without aspirin, it is giving a very good result. And not only the primary endpoint, but also the components of the primary endpoint, like myocardial infarction, like stroke, like cardiovascular death, and like revascularization. All four are individually in the same direction, and all four have got individually significant benefit. So if you see the comparative impact of a fixed dose combination with or without aspirin, you will see everywhere aspirin is scoring. But still the debate going on whether aspirin should be given in primary prevention, because the one important part is missing in all these slides is the net clinical benefit, that is the hemorrhage. We all know, this is beyond argument, that aspirin reduces all these events, the stroke, heart attack, death, everything. But it increases bleeding. So what is the net clinical benefit? That need to be more carefully analyzed before we advocate aspirin in primary prevention. And also there is a Castillo's from, it is a secondary prevention, and secondary prevention also showed the benefit of polypill, but it has to be a bit careful. And you see the primary prevention trials are uniformly positive, whereas secondary prevention trials are a bit heterogeneous. Now, the last 5-6 minutes is on the polypill in South Asia. Now, the burden of cardiovascular disease, why are we special? Ischemic heart disease will contribute to the vast majority of age standardized cardiovascular mortality burden in 2050 in the Asia-Pacific region. And peripheral artery disease will have the highest increase. So what the Asians we need, we have got high prevalence of stroke and non-ischemic heart failure, stronger association between the blood pressure and cardiovascular disease, and higher salt sensitivity. So there is a suggestion from our colleagues and our faculty over here. In 21, it came out, suggested component in a cardiovascular polypill for Asian population. You give ARB and DHP CCP with statin, with diuretic, and with folic acid, and you might add a beta blocker instead of the diuretic. The TIPS study came from India at 50 centers across India, and it showed The components were hydrochlorothiazide, atenolol, ramipril, simvastatin, and aspirin. 2,000 patient participants of 45 to 80 years, and it showed a significant reduction of blood pressure, LDL cholesterol, heart rate, platelet activity, and they were well tolerated. So the conclusion was Polycap could simplify treatment, improve adherence, and reduce cost. Estimated reduction from 62% cardiovascular disease and 48% of stroke, and particularly promising for resource-limited country like many parts of Asia Pacific. Then came the Umpire trial in India and Europe. Is a location in India, Hyderabad and Delhi, and Europe in UK, Ireland, and Netherlands. 2,000 adults with established cardiovascular disease or high risk. So it is secondary or semi-primary or 15 months follow-up. And they had two types. One is aspirin, simvastatin, lisinopril, atenolol. One is aspirin, simvastatin, lisinopril, hydrochlorothiazide. And primary outcome was adherence, blood pressure, LDL reduction, and there were secondary outcomes. And the findings were improved adherence, improved control of blood pressure and LDL cholesterol, cost-effective, and highly acceptable. Then came the top spin trial in 25 this year in Nature Medicine. It was published. Blood pressure with a single pill combination, multicenter trial, 35 hospitals across India, almost 2,000 participants of 30 to 80 of 6 months duration. And they gave amlodipine perindopril vis-a-vis perindopril indapamide, vis-a-vis amlodipine indapamide, and change in 24 hours ambulatory blood pressure, and it showed they act uniformly. Added benefit of amlodipine perindopril is that there is some reduction of sugar control as well. So a survey of availability, with this everything in background, a survey came of availability and affordability of polypill for cardiovascular disease in selected countries. And if you see, India was there, Argentina, India, Mauritius, and Spain. So India had got all these combination, as we are rather lucky that we have got all kinds of combination, and India government gives permission very easily to various combination drugs. And that is the availability, and affordability is also quite good. I don't go into the cost analysis, but they are quite affordable. And also here, there are 2 drug combination is also very common. Actually, we mostly prescribe now 2 drug combination rather than the single drugs. And the cost effectiveness also showed that as the intake increases, as the uptake of polypill increases, the cost goes down. It is quite natural. It is a market pressure. So if we can promote more and more use of polypill, it will be cheaper and cheaper. And that's a vicious cycle. If it is cheaper, there will be more uptake. If it is more uptake, it will be even cheaper. So that is very interesting point. And lastly, the Watkins work on global impact of fixed dose combination therapy on cardiovascular mortality and event from 2023 to 2050. So very interesting, I find it. And they showed the cumulative benefits of single pill combination by region. And what we see here in the South Asia region, the effect is very good. From 2040 to 2045 to 2050, we can expect a very interesting change in our cardiovascular disease pattern. And if we do the demographic decomposition, we'll also see that current care versus targeted care versus population care. So you can have the present approach or very targeted approach, or the population approach means the polypill approach. And the polypill approach should be the future. By reducing age-specific cardiovascular disease incidence and mortality rate, single pill combination therapy could also help to counter the expected increase in the number of cardiovascular deaths. You can avoid them. So that is the projected scenario, targeted versus population. So it's always seen that population approach is a better approach for resource limited countries like India. Resource not only means economic resource. You see the remote places where you cannot give. Many patients say, this medicine is not available in my area. So if you can give everything in one package, and if this package is available, then all problems are solved more or less, isn't it? So roadblock, what are the roadblock? Limited manufacturing. Many companies are not interested because the uptake is low. Affordability, Sometimes companies, to make up the lost revenue, they put their money onto the polypill adoption. If the physician's inertia, so who are the favorable patient who should get benefit? Young patient, treatment naive patient, suspected vascular disease, non-adherent type, swallowing difficulty. In the moderate risk patient, we are discussing about SCORE or young or less duration diabetes, polypill without aspirin. Okay, when the SCORE is intermediate, some other risk factor, long-standing diabetes, CKD, polypill with or without aspirin. If it is secondary prevention or primary cardiovascular prevention, the more you go to the higher risk patient, then polypill with aspirin. And advantages from patient: compliance, simple administration, less error, possible synergism of the component, greater preference, improvement in risk factor control. For us, cardiovascular disease as a holistic concept, improvement of treatment compliance, better use of time, simplified baseline therapy. We write one prescription and that's all. Healthcare system improvement in risk factor control and resource consumption. But what are the flip sides? From patient, drug discontinuation or missed dose causes absence of all the drugs. If you forget one dose, you forget all the medicines, isn't it? That's a disadvantage. Possible non-compliance with lifestyle change, not crushable, not divisible, you cannot cut it into half. Intolerance to one component, the patient will discontinue the whole pill. All the 5 pills will go away. So that is a real challenge. Healthcare professional, less flexibility for drug adjustment. So as I said, this is not for tailor-made treatment, it is for mass treatment. Not useful to all types of patient, particularly secondary prevention, possible neglect of lifestyle. Person says, I am taking one medicine which is a panacea, so I don't need to do anything else. So lifestyle may be ignored. Intolerance may, as I said, and also from healthcare system, excessive medicalization. Sometimes you don't need all the 5 medicine. One medicine can reduce your blood pressure, but you are giving 2 or 3 medicine. Maybe somewhere in excess. So my last slide, my friends, the future direction, personalized polypill, developing to tailored individual need, expanding indication could be adopted for other conditions like diabetes, like CKD. Global implementation, make the polypill more accessible in low resource setting where it could have the greatest impact. Digital health integration, combining the polypill with digital health tools such as smartphone app for medication reminder and monitoring could further enhance adherence and outcome. So I stop over here and for some discussion. Thank you.
Thank you, Dr. Ray's excellent talk. Is there any question or comment from our panel? May I ask the first question? What's the role of beta blocker in polypill therapy? Is there any difference between primary prevention or secondary prevention? Thank you.
Yeah, as you see, the polypill so far developed by Salim Yusuf and groups, etc. They use atenolol as the beta blocker. Sometimes 50 milligrams, sometimes 100 milligrams. It is no longer fashionable. So if I make a polypill today and design it, I'll perhaps give a bisoprolol 2.5 or 5 milligram because metoprolol long acting will be a bit difficult to adjust with all other components. So my preference will be bisoprolol 2.5 or 5 milligram, which is a standard dose. And for primary prevention, I know you know that it's very controversial that after heart attack, whether you should give beta blocker or not, it's every day there is a paper coming. But so far we believe that at least for year 1 or year 2, a person should be on beta blocker after a heart attack. And that should be the highest dose of beta blocker that can be tolerated. It can suddenly reduce the sudden cardiac death after an MI. It is the most effective tool. Yeah, we should be more aggressive in secondary prevention rather than in primary prevention. Yeah.
Okay, thank you. Any other question from the panel?
Doctor, there's a question that's posted in the chat. For polypills, what time will it be suitable to be given? Is it in the morning or evening hours?
Actually, now we know that time does not matter. Not for blood pressure pill, not for cholesterol pill, and not for aspirin. It only matters for sugar medicines. So, and we are not including sugar medicine in the polypill. So I think whatever time suits you. For most people, lifestyle, it suits just after breakfast. But some people definitely say it is more, I can remember more while lasting at the night before going to bed. So it's very flexible. I think it's very flexible.
Okay, any question? Okay, if no more question, we will proceed to the third
Thank you.
speaker. Thank
Thanks
you,
all.
Dr. Ray. And the following speaker is Dr. Mark Denver Tilson from Philippines. Currently, Dr. Tilson is a consultant at University of the Philippines, Philippine General Hospital, Manila, Philippines. Today, he will give a talk entitled Blood Pressure Lowering Strategy in Hypertension without or with comorbidity, spring and step implication. Dr. Tilson, please.
Thank you very much, Doctor. Thank you very much, APSC, for this opportunity to discuss the impact of these two trials in our management of blood pressure. Again, I'm Dr. Tiongson, and congratulations to the first two doctors who speak on score system as well as the polypill. It will make my discussion much easier because it will also involve those two. So, with regards to the content of this lecture, I have nothing to disclose. And here are the learning outcomes. And I hope at the end of the session, you'll be able to recognize the burden of hypertension globally and, of course, in the Asia Pacific region. And, of course, summarize the core recommendations. I handpicked the two most recent clinical practice guidelines, which is quite applicable in most areas. Again, the Asia Pacific region is quite diverse. And lastly, of course, explain how the STEP and SPRINT trials have changed our approach to blood pressure targets in specific patient groups. So let's look at first the burden of hypertension. Based on the data published by WHO, approximately 1.28 billion adults aged 30 to 79 years old have hypertension, and less than actually half are unaware that they have the condition. And again, roughly 42%, less than half of these adults are diagnosed and treated, and only 21% of these hypertensive individuals are controlled. This is really bothersome because we all know as cardiologists, as primary care providers, that hypertension is one of the leading causes or risk factors for the development of ASCVD or adverse cardiovascular events. Now, looking at our region, comparing to the European and American region, we have a significant leap in terms of prevalence of hypertension for the last 3 decades. Note that there's a 144% increase from 1990 to 2019 of hypertension individuals in the Asia Pacific region. And if we're going to look at the most recently published data in the Asia Pacific region, the data is quite diverse. Again, unfortunately, there's some paucity of data in several regions, but looking at the ranges, as you may see, our prevalence is quite diverse, reporting from 21 to 48%, with an average of 30% overall. Those who reported undiagnosed are ranging from 14 to 78%, roughly with an average of 50%, untreated ranging from 11 to 70%, roughly 40%, if you took the average, and those are uncontrolled, 17 to 80%. In terms of how do we compare to the world data, in terms of overall prevalence, undiagnosed, untreated, we're almost similar. However, in terms of control, we are faring better, probably because of awareness and because of different health programs available in several countries in the Asia Pacific region. This is very important, colleagues, that we realize the burden of hypertension, because time matters, that the longer the patient is exposed, the greater the cardiovascular risk. And you know for a fact that hypertension affects almost each and every part of your body from head to foot, causing your brain, stroke, dementia, visual impairment because of your hypertensive retinopathies. Of course, with the heart, ranging from LVH leading to heart failure and heart attack. Right now, in locally, we receive data that hypertension has overtaken diabetes as the leading cause of chronic kidney disease, leading to hemodialysis, and of course, other complications related to pregnancy and peripheral artery disease. And this meta-analysis have always caught our attention, that once your systolic and diastolic blood pressure elevates more than 115/70 to 80 millimeter mercury, there's a twofold increase already of your risk for the development of ischemic heart disease and ischemic heart disease related mortality. And this is translated across ages. When as you grow older, that the risk also increases. Similarly, with stroke, increased BP levels also translates to increased risk of stroke and stroke-related mortality. Based on this prevalence data, because of these risks that is associated with blood pressure elevation, we have revisited the classification of hypertension. I'm pretty sure majority of us were quite puzzled and of course intrigued when our American counterparts last 2017 have have changed the classification of hypertension, bringing it down to a threshold of 130/80 being stage 1 hypertension. So this got an attention because this leads us clinicians to ask ourselves if we're going to limit or lower the cutoff for hypertension individuals. The question rises that are we trying to medicalize or start treatment for those patients with previously normal blood pressure because we are used to the cutoff of 140/90 that was well accepted worldwide. And when this cutoff 130/80 as stage 1 hypertension, the prevalence of hypertension would definitely increase. Millions, if not billions, will be added among patients who are considered or labeled to be hypertensive. If you're going to notice with our European counterparts, the ESH and the ESC, notice from the optimal, normal, high, normal, the grading of their hypertension. Recently, last year, they published the new classifications of hypertension that they have or they are practicing in Europe. They have already employed the non-elevated, elevated, and of course, the hypertension. And again, the hypertension cutoff is 140/90, which is stage 2 hypertension for our American counterparts. And of course, they have labeled the elevated hypertension from 120 to less than 140 or 139 over 70 to less than 89. So again, let's try to revisit the trials which led to these changes in the hypertension classification and which will also lead us on how we approach in the treatment for blood pressure lowering. Let's look at the SPRINT and the STEP trial. To familiarize everyone, the SPRINT trial is a population which included 9,361 adults with elevated blood pressure of more than 130 millimeter mercury with an increased cardiovascular risk based on the Framingham risk score. And they were randomized either to intensive treatment with a BP target of less than 120 millimeter mercury or a standard treatment of less than 140 millimeter mercury systolic. And these are the primary composite outcomes that they measured, which include MI, ACS, stroke, heart failure, death from cardiovascular causes. And if we're going to look at the average blood pressure that was achieved in the trial, those patients who were randomized to the standard treatment, who were advised to do a BP of less than 140, were able to achieve a BP of 134.6 millimeter mercury using around 2 pills. Those patients who were randomized to intensive arm had a blood pressure average of 121.5 millimeter mercury, and they were using around 2.9 to 3 pills to achieve these targets. Looking at now at the outcomes, looking at the primary composite endpoints, notice that those patients with the intensive arm who were randomized to the intensive arm had lower or had a 25% relative risk reduction among patients compared to patients with the standard treatment. And if we're going to look at death from any causes, there is a relative reduction of at least 27% compared to your standard treatment arm. Because of the significant outcomes, the SPRINT trial was prematurely stopped instead of the 5-year observation period. They stopped it at 3.6 years because of the significant treatment benefit of the intensive arm. However, it is not without any safety concerns. It is important to take note that among patients who were randomized in the intensive group who had previous or prior history of kidney disease, there was note of significant hypotension, there was for significant syncope, but not significant fractures or fall leading to fractures, electrolyte abnormality, and acute kidney injury. So what would be our take-home point in this SPRINT trial? Among adult patients with elevated blood pressure without diabetes, target goal of less than 120 millimeter mercury resulted in significantly lower rates of fatal and non-fatal CV events and death from any causes. Now, this this study was mainly done in the Caucasian because I think the most population that they included are Americans and the Puerto Ricans. Now let's look at us and the Asian cohort. So the STEP trial, on the other hand, is also a trial on hypertension, which included 9,264 elderly patients, 60 to 80 years of age with hypertension. And again, in contrast to the SPRINT, they have more lenient BP targets. Intensive treatment had 110 to less than 130 millimeter mercury, and the standard treatment was SBP of 130 to less than 150 millimeter mercury. And the outcomes include stroke, acute coronary syndrome, decompensated heart failure, revascularization, atrial fibrillation, and death from any cardiovascular causes. Looking at the average blood pressure in these trials, the standard treatment was able to achieve a BP of 135.3 millimeter mercury with 1.5 medications, while those were in the intensive arm had an average blood pressure of 127.5 millimeter mercury with 1.7 to 1.9 pills in order to achieve these targets. And in looking at the outcomes, similar to your SPRINT trial, those who were randomized to the intensive arm had 26 lower relative risk reduction of your primary composite endpoint. And in terms of safety, in contrast to the SPRINT, there were lower adverse events, no, except for hypotension, which is defined as SBP or systolic blood pressure of less than 110 millimeter mercury and a diastolic blood pressure of less than 50 millimeter mercury. So what's our take home from the STEP trial? Among adult patients, elderly patients 60 to 8 years old, targeting an SBP of 110 to less than 130 resulted in a lower incidence of cardiovascular events. Now, looking at the classification of our European and American counterparts and applying the findings in the STEP and SPRINT trial, we always ask ourselves, when and how do we initiate treatment based on your specific profile? Again, what I really like about our newer guidelines, both local and of course, I'm pretty sure our local societies have made some statements with regard to this, is that we are trying to practice precision medicine already. And the guidelines are trying to encourage us to individualize management. So if we're going to focus in this bigger organization in terms of blood pressure control, we initiate pharmacologic treatment if the patient has an elevated BP as defined by the European Society of Cardiology as more than 130/80, which is the stage 1 hypertension, provided that they have high risk or very high risk profile, high Framingham risk score, or if you're going to look at the ESC guidelines, an abnormal score to risk, again, at considering high to very high risk. Now, standard of treatment, pharmacologic, regardless of risk, again, is recommended to be initiated among patients with stage 2 hypertension, if you're going to look at the ECCHA, and 140/90, which is the hypertension definition for the European counterparts, with a target blood pressure of 120 to 120 and over less than 80. The Americans are recommending it to be less than 130 over less than 80, but it's encouraged to achieve a systolic blood pressure of 120 millimeter mercury. To summarize the recommendation, if we're going to look at the BP level only, again, it's 140/90. But if we're going to look at the risk-based threshold, again, once your patients reach a BP of 130/80, we now take a look at the individual risk of our patient. Is the patient high or very high risk? Does our patient have clinical comorbidities that would benefit from pharmacologic therapy? Just to summarize, again, lifestyle measures is generally recommended for all hypertensive patients and those patients with elevated blood pressure. But if the BP of the patient is 130 to 139/80 to 89, if with comorbidities defined as having previous CVD, diabetes, chronic kidney disease, familiar hypercholesterolemia, or hypertension-mediated organ damage, pharmacologic management is recommended. Those patients with an estimated CVD risk score of at least 10% for patients based on the Framingham criteria, or those patients with Framingham risk score of 5 to less than 10% with abnormal risk stool test, which is score 2 for the ESC, and of course the prevent CVD from our American counterparts. And again, for patients with a BP of 140/90, pharmacologic management is recommended. Let me just go quickly on non-pharmacologic intervention. Again, salt restriction is is one of the strong recommendations. We recommend our patients to ingest only of sodium of less than 2 grams, and we are trying to advocate salt substitute because in the Asia Pacific region, particularly in our country, in the Philippines, we are very fond of salt, and hopefully we can look for salt substitutes in order to address these needs, no? And again, moderate intensity exercise of at least 150 minutes. And of course, this will be discussed later, the stable and healthy BMI and adopting a healthy diet, your Mediterranean or DASH diet. And gone are the days that we're telling our patients to take 1 to 2 servings for female and male of alcohol. It is now recommended to avoid alcohol to achieve best outcomes. And of course, restrict free sugar consumption, avoid those sweetened beverages. And lastly, again, this has been our advocate in all cardiology societies to stop tobacco smoking. Now, in terms, when we decide for pharmacologic therapy, earlier it was discussed if we're going to use a polypill strategy or monotherapy. Now, for hypertension, there's still role for monotherapy for those patients with stage 1 hypertension or elevated blood pressure as defined by the ESC, and you can use your first-line medications such as your ACE inhibitor, your ARB, your calcium channel blocker, or your thiazide-like diuretic. And if your patient is already on 140/90, you are recommended to start a low-dose combination therapy with an ACE or an ARB combined with a calcium channel blocker or a diuretic as a single pill combination, and follow-up is carried out within 1 to 3 months if you are able to achieve control. This is also echoed by our American counterparts. So how do we monitor response to treatment? It should be done every 1 month, and when you initiate, every 3 to 6 months for controlled, with a goal to achieve normotension within 6 months and at least annually for those patients who are already controlled. So to summarize, hypertension remains to be a problem globally and in the Asia Pacific region. Nowadays, guidelines are trying to tell us to individualize treatment strategy based on the risk profile of our patient. Intensive blood pressure control, and this was supported with the key findings in the SPRINT and STEP trial that intensive blood pressure reduce CV events among hypertensive patients with comorbidities. Careful consideration of comorbidities because sometimes this intensive treatment might lead to side effects. So we have to be very vigilant in monitoring and of course recommending our patient to monitor symptoms and blood pressure at home. Lastly, with the STEP trial, it tells us that age is not a barrier to target intensive treatment. Again, it is very important that careful monitoring should be done among our elderly patients because they have frailty, cognitive impairment, and of course, on top of that, as elderly, they have multiple diseases that they are being considered. Like majority of them have diabetes and other cardiovascular illnesses. And if our patients cannot tolerate, we have what we call the ALARA principle. We have to target the blood pressure as low as reasonably achievable without our patients experiencing significant side effects. So with that, thank you very much for having me here. And if you have any questions, feel free to ask them. A pleasant day to all of you.
Thank you, Dr. Tyson's excellent talk. Any comment or question from our panel? May I ask the first question?
Yes, doctor.
What is the lowest blood pressure you can tolerate? Do you just guide by the pressure only or by the symptom to maybe tapering or reduce the dose?
The dose, yeah, that's a very good question, doctor. So that's always a question for our patients, especially when they are able to achieve the optimal blood pressure targets. My barometer to decrease the dose, or if we're at the lowest dose, if the patient is already on lowest dose of combination therapy, is that when my patient starts to develop home blood pressure monitoring of less than 110 millimeter mercury. And if the patient remains to be symptomatic, like syncope, when they stand up, they get so dizzy and near fall. So these are parameters that we have to be really conscious about. So in order for us to, of course, as physicians, our dictum is to first do no harm. And as I mentioned, ALARA principle, as low as reasonably achievable, with a target BP of less than 140/90.
Okay, thank you. Any question from the panel? If not, may I ask the second question? But based on the clinical trial, it seems that intensive blood pressure lowering is a benefit, especially for the high-risk population. So right now in Philippines, do you use two combination or even triple combination as an initial anti-hypertension agent for this high-risk population?
It is recommended already by our local societies, the Philippine Society of Hypertension, as well as the Philippine Heart Association, to initiate treatment with dual combination therapy with an ACE and ARB plus a calcium channel blocker. However, the limitation is as much as you want to use a single pill combination, it is not widely available, and in our country, it's quite pricey, wherein majority of our patients pay for pills out of pocket. So we advise them to use free combinations. And again, as you mentioned, doctor, for very high risk and high risk patients, we advocate on using already combination therapy. And for those with difficult to control triple therapy, we have a pill with a statin combined with antihypertensive medication. I think that's the only multi-pill combination here, an antihypertensive and a statin. We also use that here in the country.
Okay, thank you. And any question from the panel? Okay, if no more question, thank you for Dr. Tyson's excellent talk. And
Thank you so
we
much.
will proceed to the next speaker. The next speaker is Dr. Songkit Songwatthanaroen from Thailand. Currently, Dr. Soratinos is the assistant professor, Division of Cardiology, Department of Medicine, Faculty of Medicine at Chulalongkorn University, Bangkok, Thailand. Today, he will give a talk entitled Efficacy of Lifestyle Therapy by Diet Formula and Exercise Implementation in Prevention of Cardiovascular Event, Modest but Essential. Doctor, please.
Yes. First of all, I would like to thank you, the organizing committee, on behalf of the Cardiac Prevention and Rehabilitation Society of Thailand. I would like to present about the information about the prediction and prevention of cardiovascular disease in Thailand. You know, the problem of the cardiac rehabilitation is the post-acute coronary syndrome. There is a high mortality, especially that this is the data from India, that 2008, it's about 4 to 6% of 30 days mortality in India. The same time in Thailand, the Thai history of acute coronary syndrome. In hospital mortality is about 5% in ST elevation and non-ST elevation MI. But after that, the 12 months, 1 year mortality is increased 3 times and 5 times in the ST elevation MI and non-ST elevation MI. The problem is that the patient cannot attend the cardiac rehabilitation. So the prevention program cannot do in Thailand very effectively. Only less than 20% of the acute coronary syndrome patients attend the rehabilitation. This is the data from the other country that show that the same, that 11 to 14 studies, there is a poor behavior change of the low socioeconomic for the cardiac rehabilitation attendance. This is also the barrier, that there is many barriers for the patients to attend the classical stage 1 or 1, 2, 3 cardiac rehabilitation at the hospital. So that this is the problem. That's the higher post-acute coronary syndrome mortality in Thailand. So in order to achieve this barrier correction, so we will try to search for some simple or easy way for the cardiac prevention rehabilitation. And we found that American Heart Association Life Simple 7 score has been introduced about 15 years ago. It's one of the answer of this question. We can identify the score system to be poor, intermediate, or the ideal cardiovascular health. And from the review of literature, about 10 years after the life imprisonment, there is more than 400 papers that published. And the outcome study is show that it can reduce cardiovascular mortality and all-cause mortality. This came to our study in the Thai National Health Examination Survey in the 2009 and 2014, almost 30,000 participants, and for up to 2020. And we use the 7 factors. These factors: smoking, HDL, cholesterol, fasting plasma glucose, blood pressure, fruit and vegetable intake, waist height ratio, and moderate to vigorous physical activities. We call it Thai EC9. Thai EC7. So we can classify the patient to the high risk, moderate risk, and low risk. And the all-cause mortality, also the cardiovascular mortality, decrease when the score increase. And also, we found the higher score can lower the coronary heart disease incidence hazard ratio, and also the cerebrovascular disease hazard ratio. And this is 7 factors. One is the diet. We classify into the 0, 1, 2. The goal is the fruit and vegetable intake more than 5 servings or 5 handful per day, right? And this is show that if you less than 3 handful or serving of fruit and vegetable, you have the higher mortality than more than 5. This is quite easy and quite simple for the Thai people to follow. And this is the basic for any prevention. And this is came with the study of the Mediterranean diet, that there is a very high fruit and vegetable, and also low fat dietary, and also show that it can decrease the non-fatal stroke and non-fatal MI. And this is modified that the Mediterranean diet in Thai food. We use the 2-1-1 plate. 2 portions for the vegetable, peanuts, bean, chili pepper, or sesame, and 1 part for the brown rice, and 1 part for the white meat and fish. That we can use just as in Pad Thai, 1 meal, or the Thai meal set. We can also modify this Mediterranean diet in Thai food, right? For the physical activities, usually the study use the moderate to vigorous physical activity, but in Thai people sometimes it's quite difficult. They cannot estimate, especially the low socioeconomic patients. Right? So we modify, use the step-based, also the walking step, use the pedometer, and there's some randomized trial that show that if we aim to about 600 to 700 steps per day, and after that more than 300 in 30 minutes with walking, and it showed that it can decrease the non-fatal cardiovascular disease in the UK study. Number needed to treat is only 59. And this also show in our study that if you have the ideal physical activity compared with the poor physical activity, the all-cause mortality, cardiovascular mortality also decrease. And you can modify this step-based and the time-based by you do the 6-minute walk and with the pedometer, and you know that how fast they can walk at home, and you can told that modify to the time-based, that you have to have the post-meal walking 20 minutes for three times a day, and you will achieve about 5,000 steps per day. Another thing that we encourage that they use the lifestyle physical activity. That there is a study for what they call the WILPA, vigorous intermittent lifestyle physical activity, especially the climbing stair and other physical activity. And this is a study from the UK Biobank that the incidence of the cardiovascular disease, myocardial infarction incident, heart failure incident, and stroke incident will be decreased. When you walk, average is about 110 to 150 steps per day. That it will encourage our patients to do that. And also a push up maybe less than 1 minute, vigorous intermittent lifestyle physical activity. If you do the 3 or 4 times, it can decrease the all-cause mortality. And for the waist to height ratio, we use waist to height ratio because the BMI cannot predict our population, the mortality and cardiovascular mortality. And the waist height ratio is better. So we try to encourage the patients to have their waist less than half of their height, or waist to height ratio less than 0.5. This is the goal. And we can show that if you can decrease your waist to height ratio from more than 0.6 to less than 0.5, it can decrease our cause mortality and also the cardiovascular mortality. For the HDL, we use HDL instead of the total cholesterol or non-HDL cholesterol because in Thai population data, the HDL is the most effective, the most accurate to predict the all-cause mortality more than the total cholesterol. So we use the aim to have the HDL between 60 to 100. And this is also shown in the all-cause mortality. If you can increase the HDL in both sex, right, and also decrease the cardiovascular mortalities. For the smoking, if you don't smoke, you have 2 points. If you keep smoking but more than 1 year, it's 1 point. But current smoking or quit less than 1 year is 0. So they can encourage the patient to have the more high the cardiovascular health score by quit smoking. And our data show that the ex-smoker is a higher all-cause mortality and the higher cardiovascular mortalities. This is maybe because the stress after they stop smoking. And also it tells us that you have to pay attention of the ex-smoker because the ex-smoker sometimes they back to smoke and also they have more stress than non-smoker. So we have to pay attention of these patients also. And for the blood pressure, if you know previous diagnosis of the hypertension, the blood pressure should be 120 or diastolic 80. And for the hypertensive person, if you have the antihypertensive, if you can control the blood pressure, it's a 1 point. If you cannot control the blood pressure, it's 0. And also it shows that if you have the control blood pressure, it can decrease for the all-cause mortality, cardiovascular mortality. The same as the fasting plasma glucose. If you know previous diagnosis, your fasting plasma glucose should be 60 to 100. And if you are if you with the diabetes diagnosis, if you're on the hypoglycemic agents, if you can control the blood pressure to less than 126, but maybe sometimes it's less than 60, 0, right? But if it between this, it's a well controlled, but glucose is 1 point. And it also shows that it can decrease the all-cause mortality and cardiovascular mortalities. And after that, we try to use a study in the big data in the Social Security Office, the health promotion in workplace project. And the the target population into 2023 is about 300,000 workers in Thai and also foreign workers. Screen, the hospital is about 17 hospital. We can to be 94% and found that the intermediate or high risk is about almost 90%. And we encourage them to join our lifestyle modification for 6 months. 63% of them joined the intervention. And we have the almost 150,000 data at the 6 months after the intervention, lifestyle modification intervention. And we can show that this is the curve, show that the score from 0 to 14 on the 7 factors, right? And the deep blue column can show that the pre-intervention moderate to high risk score. And after the 6-month intervention for lifestyle modification to increase their cardiovascular risk score, they can shift the curve to the right, and so they can increase the 1.44 cardiovascular risk, cardiovascular health score. And every one CV health score increase was associated with decrease the all-cause mortality and also the cardiovascular mortalities. So we hope that this intervention can help to decrease the mortality in the post-MI or post-acute coronary syndrome patients. And 2022, American Heart Association also announced the Life Essential 8 at the 8 factors that the sleeping health is the 8 factor to add. For the lifestyle, for Life Essential 8, there's been 34 observation study in 2023, only 1 year, and then can prove that it can decrease cardiovascular or cosmetic cardiovascular mortality, coronary heart disease, and stroke. And so we try to add the 8 factors into our 7 Thai EC7 by using the 0, 1, 2 score, the same that modified from the American Heart Association Essential 8 score. For the alcohol, which is the 9th risk factors, this is the study, prospective study from the EGAT, Electrical Generating Association of Thailand study, for 30 years and they divide the alcohol drinker to 4 subtypes, right? And they found that the ex-drinker or irregular drinker has a high mortality than the regular eater drinker, right? So this is the same as smoking, that if you quit alcohol, stop alcohol drinking, there should be some more stress, and you have to pay attention. This kind of patient maybe can increase mortality more than you still drink alcohol. But in the cardiovascular mortality, there is no difference. So we don't find any benefit effect of alcohol drinking in Thai people. And we modify them to be the maintain abstinence and or occasional drinker and regular drinker. And we can show that the all-cause mortality and cardiovascular mortality also can decrease. So this is the score, our cardiovascular health score. Use the food and vegetable physical activity, use whether it's step-based or time-based. Best high ratio, HDL, cholesterol, smoking, alcohol drinking, sleeping duration, blood pressure, and fasting plasma glucose. This is the 9 factor. We call it Thai EC9, or cardiac prevention and rehabilitation Thai EC9. So from the American Heart Association Life Essential 8, we modify into the cardiac prevention and rehabilitation Thai EC9. We use only 5 minutes to do the cardiac prevention rehabilitation. So we hope that we can provide the EC9 to every cardiac patient to increase the all-cause mortality and cardiovascular mortality. And after that, maybe the Thai EC9 may be the new vital sign in the other Thai people. This is I will finish here. I'm happy to have any question. Thank you very much.
Okay, thank you, Dr. Senwa Taronario. Excellent talk and share very important information from Thailand Easy Thailand data. And any question from our panel? Let me ask the first question. The picture you show the Thai Mediterranean diet looks delicious, but in Taiwan, we're facing some problem because most of our people eating outside, and we don't have time to prepare for the diet for Mediterranean Thai. So may you share some experience how to prepare the Mediterranean diet in Thailand? Thank you.
I think that there's usually the Thai food and Mediterranean diet. There are many things that may be equivalent. It's maybe not the same, such as the monounsaturated fatty acid. With Mediterranean diet, usually they use the olive oil, right? But in olive oil, it's very expensive in Thai, and also it's very hard to find in the rural area. So we use the same monounsaturated fatty acid, such as the sesame seed. Usually in the Thai food, there is a sesame, black sesame or white sesame, and also the rice grain oil that's used from the rice, and also the peanuts, also the really high monounsaturated fatty acid, and also there are many kind of instead of use the olive oil as the Mediterranean, we try to modify it, and we are going to have some modification. And the aim that the basic for the diet is the fruit and vegetable more than 5 servings per day. So we encourage everyone to have at least 1 spoonful, or no, handful, not spoonful, handful of the fruit and vegetable every meal, and the 2 handful of the vegetable and fruit every day. So together they could have 5 servings per day. That is very easy, and it's very practical to tell the patient and use very little time to show them that what they will do when they're back to home after the acute MI.
Okay, thank you. Any question from the panel? And I found the enough sleep is very important for lifestyle modification. I found more than 7 hours sleep is suggested in your slide. Any further comment about this? Thank you.
Yes, but the problem of sleep is that it's subjective. The patient will tell us that how many hours that they sleep, that we don't know that is the average or the longest or the shortest sleep duration of every patient. That sometimes we have to have some objective measurement, such as the active graph, and to show that when they lie down and how many hours, or any sleep test. So we wait for this kind of the data that to show that sleep, that there are also many sleep health study for the cardiovascular prevention that have systemic review. We show that if less than 4 hours per night is very high risk, and more than 9 hours or 10 hours per night is also the high risk. Also, you sleep too much, it also you have less physical activity, less exercise. So too much is not good, and also too little also is not very well.
Okay, thank you, Dr. Senwa Tanoroy. Excellent talk. And if no more question, we proceed to the next speaker. The next speaker is Dr. Hani Sabro from UAE. Currently, Dr. Sabro is an assistant professor of cardiology at the Brown University Upper School of Medicine, Rhode Island, USA, and also a consultant in cardiology, advanced heart failure and pulmonary hypertension, and cardiac electrophysiology at the Mayo Clinic, Abu Dhabi, UAE. Today, he will give a talk entitled Medical Weight Management by Nutrient-Stimulated Hormone Therapy, GLP-1 GIP receptor agonist in prevention of cardiovascular event, Asia Pacific, a point of view. Dr. Sabro, please.
Thank you very much, Professor. And really, it's a great privilege to be part of this very important and very wide-scale topic. I'm just going to share my slides. Just checking, are the slides visible?
Yes, you
Excellent.
can see it.
Okay, so let's just put on full screen. And thank you for the kind introduction as well. So I think one of the things we've learned is that obesity drives a lot of cardiovascular risk. And in the region, we have different types of obesity, which was very nicely shared by the previous speaker. We don't always depend on BMI because we also have this visceral obesity phenotype, which I think now in the guidelines, we talk about waist-hip ratio and waist circumference. So this is my contact information. If anybody would like a copy of the slides, please take a picture of the QR code and send me a WhatsApp message. I'm more than happy to share the slides in detail. So I've taken a little bit of liberty with the title from CV protection with GLP-1 versus combined GLP and GIP. Is it the weight loss or is it the molecule? I'm going to review also with you the updated RCT evidence. So I'm going to go back a little bit in history and just try to remember what happened during the COVID pandemic. During the COVID pandemic, all of us, whatever your specialty, whatever your, we all learned to become COVID doctors. Now we all need to be cardiometabolic doctors since this pandemic of synchronized obesity and associated cardiometabolic. I'm sorry? Okay. Since the current pandemic worldwide of obesity-related and cardiometabolic diseases is not stopping or even slowing down. My primary disclosure is that all honoraria are donated to patient-supporting charities in UAE. The global prevalence of obesity, which is a key factor of cardiovascular disease, is a syndemic of obesity and cardiovascular disease. By 2030, 1.5 billion people will have obesity. Currently, almost 1 billion people have obesity. And if you think about it, what's the other side of this equation? About 5 million people, 500 million people have had cardiovascular disease. Almost 50% of deaths globally are due to cardiovascular disease and coronary artery disease and related to cardiovascular disease. So there is a direct relationship. Now, as you have increasing overweight and obesity-related cardiovascular deaths, it is attributable. Almost 2 million cardiovascular deaths were attributed to elevated BMI in 2021, and 70% of deaths are related to overweight or obesity are due to cardiovascular disease. You can look at this from 1999 to 2020. While CV mortality has decreased because of many evidence-based interventions, including primary PCI and good medical therapies, over the past 2 decades, obesity-related CV deaths have increased by threefold. So where I live in the UAE, we have a lot of cardiometabolic risk. And remember, this is a multifactorial process. At least a third of our patients are dyslipidemic, another third are hypertensive, 60% of the population, including young people, are obese or overweight, and sedentary lifetime. In a recent household study, only 17% of patients do moderate physical activity. So it is not surprising that this statistic of cardiovascular death is increasing year after year. 34% of all deaths in the UAE are due to cardiovascular disease in patients below the age of 65. So to try and assess and solve this problem, the Emirates Diabetes Society and the Emirates Cardiac Society went hand in hand in 2023 to create a guideline to look at cardiometabolic risk and assessment and management. Now, this was published in Dubai Diabetes Journal 2023. And I just have to say that we utilized the terminology of CKM before the American Heart Association. This was published in in May, and this was published in AHA 2023. Regardless, the concept is the same. You start with excess adipose tissue, which results in visceral obesity, impaired glucose tolerance, then leads to increased risk factors, which is triglyceridemia, hyperlipidemia, overt diabetes, worsening of CKD, worsening of hypertension, and metabolic syndrome, subclinical stages of disease, including subclinical atherosclerosis, subclinical heart failure, and not to forget early stages of chronic kidney disease, and then late stages of cardiovascular disease, overt MI and overt stroke, peripheral artery disease or amputation, atrial fibrillation, and of course, death. So our objective, of course, is to prevent progression to complications. Now, beyond coronary artery disease, cardiokidney metabolic syndrome is a disease of progressive multi-organ damage with obesity as the root cause. Weight gain, obesity, and inflammation lead to decline of general metabolic health. Each condition increases the other. Adiposity increases insulin resistance, which then promotes hypertension, which then increases dyslipidemia, type 2 diabetes, and inflammation. And all of these risk factors drive complications, including peripheral artery disease, fatty liver and metabolic associated steatohepatosis, chronic kidney disease, and cardiovascular disease. Now, this forum is a cardiology forum, but remember, all of us see obese patients, and each of us sees patients from their own perspective. The cardiovascular disease list is long. Obesity-related disease includes stroke, dyslipidemia, hypertension, coronary artery disease, HFpEF, atrial fibrillation, peripheral artery disease. But not to forget, of course, that you can have osteoarthritis, fatty liver, depression, anxiety, and even worsening of cancer. So we should really see the same patient in the context of risk prevention and organ protection. So when you think about this chronic cardiokidney metabolic disease, this is obesity at the center, in the center red circle. These CKM diseases occur simultaneously in the same patient. The same patient can develop diabetes, can develop obesity, can develop cardiovascular disease, and as the disease progresses, more complications are visible, such as fatty liver and liver cirrhosis, CKD with worsening, peripheral artery disease, MI, and stroke. So the same patient shares the same risk factors, leading to multimorbidity over time and leading to severe outcomes in the gray bar on the outside. So we really need to take a holistic approach and look at obesity as an important modifiable risk. Now, I'm going to just stop for a second and look at peripheral artery disease. Patients with peripheral artery disease actually intersect with both coronary artery disease, cerebral vascular disease, and they often have coexistent disease in multiple vascular beds. So, in fact, atherosclerosis is a general widespread vascular problem, and the PAD also allows us to have a clue. The other important point that we've realized from the interventional studies, which we'll discuss a little bit later, is that obesity and systemic inflammation both contribute to progression and destabilization of plaque, and systemic inflammation leads to plaque rupture and acute ischemic events. There is a very complex but well-defined relationship between obesity, inflammation, and cardiovascular disease, as well as kidney disease. In fact, all of these inflammatory cytokines lead to inflammation and increase of C-reactive protein, lead to oxidized LDL and increase in PI1, lead to ectopic fat, which leads to both heart failure and preserved ejection fraction and renal function as well. So to summarize, when you have obesity, it is not only a disease of the adipose tissue, it is a systemic inflammatory disorder that manifests with endothelial dysfunction and cardiovascular disease, with hepatic dysfunction and increased insulin resistance, with muscular dysfunction and increased insulin resistance, and of course, increased production of multiple inflammatory cytokines. So when you look at the risk factor as a risk factor, obesity contributes a significant component of worsening blood pressure, directly and indirectly, increased blood glucose, increased blood lipids, and inflammation, which then promotes the triad of atherosclerosis and thrombosis and ultimately leads to cardiovascular events. Now, what is the actual contribution of overweight or obesity? So this is a very large study where they looked at patients who had obesity only and 0, 1, 2, or 3 additional conventional risk factors. Simply having obesity with the no other metabolic abnormalities increased your hazard ratio of coronary heart disease, whether you're obese, by about 50% and overweight by 30%. From heart failure standpoint, it almost doubles with no other risk factors. So obese is almost double, and overweight is 1.6%, 60% higher. So you see that only obesity, without the progression to other risk factors, contributes tremendously to events and heart failure as well. So we have come to realize, and mostly from interventional as well as observational studies, that visceral and abdominal obesity is the root of all cardiometabolic diseases. So why not attack the root? Cut the root instead of having to deal with this vicious cycle. You can see very clearly that now we understand that cardio-kidney metabolic disease are all intertwined like a rope with 3 threads. In red, we have cardiovascular disease. In blue, we have kidney disease. And in white, we have, or gray, we have the diabetes and metabolic risk factors. Why not attack the problem at the earliest stage of endothelial dysfunction before it results in atherosclerosis, before it results in albuminuria, before it progresses to MI and stroke, before the CKD worsens, before overt LV remodeling, before end-stage kidney disease and cardiovascular death? So the earlier we apply these red crosses, the more effective we're going to be in preventing events. So for decades, we have all been slipping at the branches of the CKM disease complications, one piece at a time, and separately in separate specialties. So the neurologist deals with stroke, the electrophysiologist deals with AFib, the gastroenterologist deals with liver disease, the cardiologist deals with MI and stroke, but we're not looking at the entire problem. The problem here is this obese central obesity, which is actually, this is a tree from native to Madagascar and southern part of Oman, which is called the baobab tree. As you see, it's an obese tree with a lot of complications at the end of it. So why not cut the problem from its root and cut the cycle from its origin? So when you look at the residual risk of cardiovascular disease in patients with cardiovascular disease and overweight or obesity, you still have additional risk factors that can be tackled through the management of obesity. So one of the, this is an analysis of all of the obesity CVOTs and registries looking at pharmacotherapies. SELECT is the most recent study that was published last year that looked at a very specific outcome, triple-point MACE. All of the other studies using lorcaserin, naltrexone, bupropion, rimonabant, and sibutramine were actually negative. SELECT was a remarkable study because it was strongly positive and showed us a very different approach to management of obesity. We have recently seen the results of SURMOUNT MMO, which I'll present here. So some data for tirzepatide also exists, although I have to say that the data is relatively small and recent. This is the SUMMIT study, which is the use of tirzepatide versus placebo in patients with heart failure and preserved ejection fraction, presented last year in November at AHA by Milton Packard. So tirzepatide compared to placebo in patients with HFpEF resulted in a reduction of heart failure events, but had no difference in cardiovascular death in patients with HFpEF and obesity. More recently, you might have heard that was just presented in September 2025 at EASD, the SURPASS cardiovascular outcome study. Here they compared the combined GLP-1 GIP receptor agonist, tirzepatide, versus dulaglutide, which is a earlier generation GLP-1 receptor agonist, from the same sponsor, mind you. And what they showed here, there was a non-inferiority regarding MACE. It was not superior regarding MACE, unlike the other studies, and the HbA1c was significantly reduced, including the weight. So this is an editorial that was published shortly afterwards from some of the experts, and it shows that while the tirzepatide produced larger A1c reduction and greater weight reduction and stronger renal protection than dulaglutide, it failed to show statistical superiority in MACE events. Now, in this study, the patients were already on contemporary use of SGLT2 inhibitors, and they were also aggressively up-titrating the tirzepatide to the maximum tolerated dose, while the dulaglutide was at 1.5 milligrams as per the REWIND study and the label. Given the cardiometabolic advantages and modern background therapy and dosing, failure to establish superiority is disappointing and may suggest that the mechanism, the combined mechanism, may not be as effective. Now, I'm going to take you back in history to another study. This is the Harmony outcome study, which was actually published more than 7 years ago in The Lancet. This is a study of another GLP-1 receptor agonist called albiglutide. So there were 8,000 patients in the study, and albiglutide showed a significant, almost a 25% reduction of MI, fatal and non-fatal stroke. And the curves diverge very quickly. And you see that there's a big absolute risk reduction compared to placebo. What was the weight change in this study? Almost nothing. 0.6 kilograms compared to placebo and 0.8 at week 16. So there was almost no impact of weight, yet there was a tremendous reduction, almost a quarter, and in relative risk reduction for MI and MACE. So Dan Drucker, who was actually one of the godfathers of GLP-1 receptor science, tells us that weight loss cannot be the answer for specific GLP-1 induced cardioprotection. It's a molecule-specific effect. And here, this is actually the proof. Indeed, this medication is no longer in the market in spite of a positive outcome study because the manufacturer realized they could not compete in the weight loss market. It doesn't reduce weight, but it's very powerful. What's more important to me as a cardiologist is actually the outcome, not the weight. So now we're going to delve deeply into the SELECT study. This is a remarkable landmark study where they looked at 17,000 patients, 41 countries, who were overweight or obese, defined as a BMI above 27, and had established ASCVD. Now, the exclusion criteria was diabetes. You could not be diabetic in this study. You had to be non-diabetic. They were followed for 40 months. Remember, again, the exclusion criteria: any patient with an A1C above 6.5, any type 1 or type 2 diabetes, any treatment with glucose-lowering agent, that's exclusion. Now, did they include patients with prior MI, prior stroke, and symptomatic peripheral artery disease above 45 with a BMI above 27, not particularly obese? The endpoints were death from any cause, non-fatal MI, non-fatal stroke. There was a secondary endpoint group, which was, again, death from any cause, composite heart failure endpoints, and, of course, changes in body weight and BMI and waist circumference. This is the first study to show MACE reduction in patients with overweight or obesity and cardiovascular disease without diabetes. 20% reduction of MACE, and the curves diverge literally within 6 months. 19% reduction of all-cause mortality, 22% reduction of kidney disease, 73% reduction in new onset of diabetes. The MACE endpoint was very, very rapidly achieved. Hazard ratio, almost 37% reduction within the first 3 months, 40% reduction within the next 6 months, and it continues to diverge compared to placebo. Now, was this driven by weight or something else? This is the surprising evaluation. If you looked at these patients, regardless of their baseline body weight, if their BMI was less than 30 or over 40, if their body weight was an absolute number less than 87 or more than 101, if their waist circumference, and this is particularly important in the Asia-Pacific region, was greater than 100 and less than 106 or greater than 116, again, positive. And if the patient had a waist height ratio more than 0.6 or less than that, no difference. All the patients, by whatever anthropometric measure of obesity or visceral or waist circumference, had a benefit. You didn't have to have a very high BMI to benefit. Now, I think this is even more important. On treatment, at week 20, patients who lost less than 5% or even gained weight had a 15% reduction of MACE, and patients who lost more than 5% had a 33% reduction of MACE. So everybody gained a MACE advantage, whether they had a high BMI or not, or weight loss or not. So this clearly suggests it's an independent mechanism related to the molecule. In graphical terms, I think it's even more obvious. The placebo patients who lost more than 5% had a 12% proportion of MACE. Semaglutide patients, regardless if they lost more weight or did not lose weight at all, had a 4% difference. And you see how quickly the curves diverge. It is remarkable, and it proves that it is the semaglutide molecule, not its weight loss effect, that's causing the benefit. Now, as you know, the guidelines have changed and the FDA label has changed. In the new ESC primary and secondary prevention guideline recommendation, chronic coronary syndrome patients without type 2 diabetes specifically mentions semaglutide by name because of the SELECT study above BMI above 27, or obese patients without diabetes to reduce CV mortality, MI, and stroke. And in patients with diabetes and overweight or obesity, glucose-lowering medication, GLP-1 receptor agonists to reduce weight, particularly semaglutide and dulaglutide, to reduce weight and improve the coronary artery disease component. So SELECT is truly a landmark study in many ways. It has shown us that there is an anti-inflammatory, anti-atherosclerotic effect of this specific molecule. The consistent reduction of MACE with semaglutide compared to placebo, regardless of baseline adiposity by any definition, regardless of the extent of weight loss, even weight gain, significant reduction of MACE, suggesting an alternative mechanism of improved cardiovascular outcome. And in fact, many patients with overweight or obesity, by whatever definition you like, whether it's waist circumference, waist-hip ratio, conventional BMI, or absolute weight, not only those who lose weight may derive a benefit. Now, I'm just going to briefly talk about HFpEF and obesity. 85% of HFpEF patients are obese, more than twice the general population. Obesity increases insulin resistance and impairs cardiac arterial tone. Visceral fat is an independent predictor of HFpEF. One of the things we saw in the STEP-HF study, which looked at semaglutide versus placebo in the obesity phenotype of HFpEF, regarding physical function, weight, inflammation, and symptoms, there were 520 patients who received semaglutide versus placebo, all of whom had heart failure with preserved ejection fraction, and they did include countries from Asia as well. The change in the KCCQ significantly improved with heart failure, and there's at least 7.5 points change, significant within very early stages. Of course, the mean body weight decreased compared to placebo. That's what we expect, almost an 8% difference compared to placebo. And the 6-minute walk distance significantly improved by a factor of almost 27 meters, early and continuous afterwards. The overall group of studies with semaglutide were then analyzed and presented last year at ESC. I don't know if you attended. This was a really brilliant lecture. So Dr. Kusiborod analyzed patients from SELECT, which was cardiovascular disease, FLOW, which was renal disease, STEP-HF, which was HFpEF, and STEP-HF diabetes, and put them all together for an analysis on heart failure outcomes, which was pre-specified. So in the SELECT study, about 24%, 4,000 patients, had heart failure at the beginning, of which half were HFpEF and the rest were reduced ejection fraction. Semaglutide in these patients, remember this is not diabetes, in the SELECT study, showed a reduction of heart failure events, new onset by 15% and recurrent by 21% compared to placebo. Reduced heart failure events in both HFpEF and HFrEF, 21% in HFrEF and 25% in HFpEF. Now, when this was combined with the other studies, the renal studies and the diabetes studies, right, what did we get in patients with HFpEF? 74% of the patients in this analysis are not diabetic, and they're quite sick, and they have a high BNP. But the common factor is that 90% of them, 99% of them, had a BMI 27 to 30, 30 to 35, or above 35. Less than 27 was not there, and they were all good standard of care. What happened here in this large pooled analysis, which was pre-specified, a 31% reduction in the semaglutide arm of CV death or heart failure events. How does it do it biologically? There's an 18% reduction of an NT-proBNP, whether the patient has AFib or not, and a 36% reduction of C-reactive protein, which I think also comes back to the idea of epicardial adipose tissue. So remember, when we were shocked by the SGLT2 studies that showed a complete rethinking of the intersection between CVD, diabetes, and CKD, can we apply the same mindset now to GLP-1 receptor agonist? This is the old story, the pumps, pipes, and filters that Professor John McMurray and Sumodh Verma thought about with SGLT2 inhibitors. What is happening with the GLP-1 receptor agonists? Very important when you look at the STEP-HF study, which again, semaglutide versus placebo in a well-managed cohort of of heart failure with preserved ejection fraction, left atrial volume decreased in semaglutide, less LV hypertrophy, diastolic improvement, significant improvement in diastolic function with semaglutide compared to placebo. So this is all showing us that we are causing some remodeling with LV function and diastolic dysfunction in particular with semaglutide, a GLP-1 receptor agonist. Now, what about safety? When you look at patients where you're trying a new therapy, think about this. So there were fewer adverse events with semaglutide, and permanent discontinuation were there mostly due to GI side effects. Gallbladder events, acute kidney injury was actually lower. Now, I'm going to share with you something also very recently published, which was something called the SCORE study. The SCORE study looked at MACE and all-cause mortality in patients started on semaglutide in routine clinical practice. This is a real-world study in patients with obesity and overweight, and there are big representation from the Asia-Pacific region. Compared to semaglutide, there was a reduction, 45% lower, of 5-point MACE, and semaglutide use was significantly lower in terms of 5-point MACE, which is extended to include cardiovascular events of all types. The MACE was also analyzed as 5-point MACE or 3-point MACE, so MI, stroke, and all-cause mortality. CV mortality was the initial one. And then, of course, they also added hospitalization for heart failure as a very powerful endpoint and coronary revascularization. When you look at the revised triple-point MACE, it's still 30%. Revised 5-point MACE, 22% advantage. Per protocol analysis, even a larger compared to tirzepatide. And I think this is one of the important points of this study. They were comparing patients on tirzepatide. I forgot to mention that at the beginning. Comparing patients on tirzepatide versus patients on semaglutide. So semaglutide confers a specific MACE advantage compared to tirzepatide. You see the significant change, and it's very rapid, as you see, 43% compared to tirzepatide as well. So this is the outcome of the STEER study, which was presented at ESC, actually. This is a real-world study of patients with overweight and obesity without diabetes, lower risk of CV events with semaglutide compared to tirzepatide, and therefore it's a molecule-specific approach, 29% intention to treat analysis and 57% on treatment analysis. One final thing that's kind of important for us to consider, atrial fibrillation. This is a systemic review and meta-analysis that was also published last year on the prevention of atrial fibrillation. And again, a significant difference compared to other agents in terms of reduction of atrial fibrillation. So in this study, they looked at 21 trials with 25,000 patients. Semaglutide reduced AFib recurrence compared to other control drugs, compared to other anti-hyperglycemic medications. The outcome was favorable in diabetes, and the results varied by type of semaglutide. Oral semaglutide showed a 50% reduction. Subcutaneous showed a 33% reduction. So overall, semaglutide reduces AFib recurrence in the overall analysis. So finally, just to highlight the following point. The GLP-1 receptor agonist class is not a class effect in either diabetes and obesity, and protection of the cardiovascular, renal, hepatic organs is evidence-based and not dependent on the extent of weight loss, as we saw in the SELECT study. So it's very important to respect the evidence in terms of long-term safety and efficacy. And if you look at the current updated FDA label for semaglutide, specifically because of the SELECT study and its sub-analysis, FDA has approved semaglutide 2.4 milligrams to reduce the risk of heart attack in addition to its initial weight loss purpose because of a 20% reduction of heart attack and stroke. When I look at the data that's been published at this point, as I mentioned, we're trying to be objective, but there is little data coming from tirzepatide from the cardiovascular space as of yet. Hopefully, we'll see some more data at the end of the year. But semaglutide reduces all-cause mortality and produces organs in all CKM diseases. It reduced cardiovascular all-cause mortality in patients in the SELECT study, which was an obesity, not diabetes study with cardiovascular disease, FLOW study, which was a renal disease patients. In the ESSENCE study, which was recently also published, 37% reduction of fatty liver disease by confirmed biopsy fibrosis. Cardiovascular outcomes in SELECT and SUSTAIN 6, between 20 and 26% reductions in MACE. Heart failure outcomes, almost a 70% reduction of heart failure events or CV death in the STEP-HF study, and the kidney outcomes in FLOW, also a major reduction of renal disease events. Thank you very much for your time and your attention. And again, this is my QR code. If you need a copy of the slides, please take a picture of it, send it to me on my WhatsApp, and I'm very happy to send you a copy. Thank you.
Okay, thank you, Dr. Sabro. Very comprehensive and important talk about the GLP-1 on GIP medication. I think based on your speech, this increasing base drug is not only an anti-diabetes agent, but also a cardiovascular risk reduction agent at this moment. Any comment or question from the panel? Okay, I have one simple question, but maybe it's a FAQ. Right now, do you know why this increasing base therapy is beneficial for cardiovascular disease? What's the mechanism? Thank you.
Sure. Thank you very much. It's a really excellent question. So to begin with, in the animal models where this medication was developed, they actually have an animal MI model where they embolize the LAD and then they give the therapy. And it reduces, first of all, infarct size early. It has a very definitive effect on the vascular endothelium, including stabilization of the inflammatory cytokines and the activated macrophages and the foam cells. In addition, it has a very powerful reduction on the high sensitivity CRP. So I believe high sensitivity CRP is one of these hidden biomarkers that we haven't tackled before because we didn't have good treatments. And there's a little bit of controversy on the use of colchicine. But clearly, in the systemic inflammation driven by obesity or in patients who have ectopic adipose tissue, there's a significant improvement in hsCRP. Actually, the hsCRP reduction in the SELECT study was greater than what you get with statins, almost 39%. And this is correct across the board in diabetes and non-diabetes patients. There's another additional mechanism is that by improving the hepatic fat content, right, which is the ectopic fat around the liver, the production of IL-6, which again leads to the inflammasome and CRP, is also being reduced. And there's also some studies from Subodh Verma's group in Canada that they look at the ectopic adipose tissue around the fat. So what we used to call the benign fat pad, it's not a benign fat pad at all. It's literally pumping cytokines into the wall of the myocardium, leading to changes in diastolic structure and function. So I think these are the multiple pathways that the molecule is working on.
Okay, thank you. I think we should, for the anti-inflammation, maybe we'll wait for the anti-inflammation dedicated trial using anti-interleukin-6 monoclonal antibody, such as Hermes trial and the Luz trial in the future. So if no more question, I thank you, Dr. Sabas, excellent talk. We will proceed to the sixth speech. The sixth speech it will be delivered by Dr. Hannah Oscar from Pakistan. Currently, Dr. Oscar is an assistant professor at the National Institute of Cardiovascular Disease, Karachi, Pakistan. Today, she will give a talk entitled Global Burden of Cardiovascular Disease in Women, Future Specific in Asia Pacific region. Dr. Oscar, please. You are muted now. Please share your slide.
Did you see them?
Not yet. Okay, yes, we can see it.
Good morning, everybody. This is Dr. Hanaskar. I'm a cardiologist working in an ICVD, and I actually started a cardiometabolic program, and my interests are cardiometabolic disease and cardiobstetrics. So this is the outline of my talk. I'm going to talk about introduction, and then I will talk about global burden of disease, especially relating to women, and then care across a woman's lifespan and focusing on female-specific risk factors. So cardiovascular deaths are responsible for approximately 35% of all deaths in women. And as we have all talked about in this webinar about everything contributing socioeconomic, environmental factors, community factors, and as the recent epidemic of cardiometabolic disease, mainly driven by abdominal obesity, and with the recent publication of guidelines by the American Heart Association on cardiometabolic syndrome, it all starts with obesity, which was initially thought of as benign ectopic fat, but now we know, as Dr. Hani Sabur really nicely talked about, the interleukin and inflammatory cascade leading to vascular inflammation and cholesterol deposition. The problem of cardiovascular care in women has been long recognized, and with AHA publishing the Go Red campaign in the early 2000s, it brought about decreases with the increasing awareness, because women, as we all have seen, not only have atherosclerotic cardiovascular disease, but the recently recognized syndromes of INOCA and MINOCA. And also there has been a delay in diagnosis, because most of the time they present with atypical symptoms, back pain, nausea, dizziness. So there's delayed in treatment, delayed in diagnosis, and under treatment. And of note, most of the trials which have been done, RCTs for lipid-lowering therapy, and all the GDMTs for heart failure, and the percentage of women was frequently lower than 20-30%. So it's the increasing recognition now that women-specific trials and women are being included more in trials. So global burden of disease is a consortium of, it's a multinational research collaboration between University of Washington, Seattle, with their IHME Institute, WHO, and National Heart and Lung Blood Institute. And they got together, and they have had certain publications out in 21, 23, and the most recently a week ago on the incidence and prevalence and mortality rates causing from different areas of the world. So global burden of cardiovascular disease is responsible for 437 million disability-adjusted life years. And as we can see from this slide, that there's a 42.9% increase in males and 28.6% increase in females. And as we talked about in this, most of this has been driven by obesity, with the metabolic epidemic, which is taking every organ by storm: the kidney, the liver, the heart, as contributing to heart failure, hypertensive heart disease, and obviously atherosclerotic cardiovascular disease. And the numbers are heterogeneous all over the world. As we can see, in the disease is concentrated more in Africa, and this is and India, South Asia, Pakistan, Central Asia, Eastern Europe, and this is driven mainly by, when you look at the gross national income per capita, by poverty, as social demographics are increasingly being recognized as a cause of poor, access to healthy food. We talked about, the previous speakers have talked about healthy diets, how more than 5 servings of fruits and vegetables are actually beneficial for reducing the risk of CVD. So when poverty comes, when there's less access to healthy food. So it's a combination not only of the genetic risk, but also the environmental, and with climate change. So it's a holistic now approach to approaching the patient. So it's a highly prevalent condition, and it's not only ischemic heart disease, rheumatic heart disease, hypertensive heart disease, lower extremity arterial disease. It's causing global deaths wide world. And the initial data came from the US when they noticed that South Asians living in America, and the UK Biobank showed that patients of Pakistani, Bangladeshi, Indian origin are at a higher risk of CVD. And this is just a publication from 3 days ago. It was published in JACC from the age standardized disability adjusted life years. So high income Asia Pacific had the lowest, as you can see over here, compared to the South Asian region, as you can see over here. So there's again a very, even in South Asia, there's heterogeneity in the age standardized daily for ischemic heart disease. As far as age standardized dailies for rheumatic heart disease, we can see like this region of South Asia is doing again heterogeneous, with Asia Pacific more doing much better than South Asia, again determined by the social demographics. South Asia has the second highest for females for dailies compared to males, and the highest high-income Asia Pacific region had the lowest rheumatic heart disease burden in 2023, with 12.5 age standardized daily for females and 11.4 for males. So again, heterogeneity, and again driven by the socioeconomic stature of the infrastructure of the country. So even for stroke, there is the same, it follows similar patterns. Stroke is more related to high blood pressure, and ischemic stroke again was the third large cause of disability adjusted life years among CVD. Same for hypertensive heart disease, that is more in the sub-Saharan Africa, Northern Africa. But again, you can see in the Asia Pacific region, the numbers in the more where the social developmental index is better, those countries are faring much better than countries where the social development index is poor. As far as women are concerned, there is variation in the temporal trends and age standardized CVD, and that follows a socioeconomic gradient. And as we can see, there's annual increases were evident in East Asia, South Asia, and East Asia. But there was decrease in the high-income Asia Pacific. And this is the general trend which is following. So the top three causes of cardiovascular death in women were ischemic heart disease, stroke, and hypertensive heart disease. And the annual age standardized mortality rates were highest in Central Asia and lowest in high-income Asia Pacific. Again, this follows the same pattern of, social development index, human development index. And among the South Asian region, if you can see Pakistan, the women have a higher mortality because of high blood pressure and low intake of vegetables and fiber. And this is data comparing. This is also a recent study which was published just in the last month in August. Sorry, not 2 months ago. It's sex disparities. They looked in ischemic heart disease mortality in Asia. And they looked at the ASMR to ASPR index, and significantly higher in women, more in Pakistan than in any other countries. Again, even in South Asia, there's heterogeneity. And again, it comes with education, better access to food, better lifestyle choices. So this is the trends in the ASMR in ischemic heart disease, and from 2005 to 2021. This is for men and this is for women. And as you can see in Pakistan, again, it was high in 2005 as well as in 2021. And similarly in Nepal and India and Bhutan is the only country where actually it was lower in 2021. If you look at men, it's similarly higher in Pakistan in 2021, in Nepal, in India, and in Bhutan also. Bangladesh was the only country where it was lower. And if you look at the standardized prevalence rate, the prevalence of ischemic heart disease in South Asia has increased. Again, the increase is more in women at 8.9% compared to men. So again, women have more of, as we talked about, central obesity. Again, so this is what is driving this epidemic of CVD in women. So Bhutan was a country which saw a lower in 2021 compared to the 2005. And there's a significant negative correlation between the age standardized mortality rate to ASPR index and gross national income per capita. Again, we're talking about the social demographic determinants of health. So in 2005, most South Asian countries exhibited a higher ASMR to ASPR index for women compared to men. However, Pakistan in 2021 was the only country that is showing that women actually are doing poorly as far as their cardiovascular health is concerned compared to the men. So when we look at risk factors, they generally fare similarly between men and women. In Pakistan, the ratio is closer to 1. But in other countries, LDL was more of a contributor in men. If you look at high systolic blood pressure in Pakistan, a big contributor, women having hypertension, similarly to men, as a cause of CVD compared to other countries. If you look at tobacco use, again, women in Bangladesh, Bhutan, India, Nepal, Pakistan, they use tobacco less frequently, and so they're attributable to ischemic heart disease attributed to tobacco use is lower. And so, as far as fasting plasma glucose is concerned, Pakistan and similarly the number is approaching 1. So similarly, it's contributing both in men and women. So as you can see, there's heterogeneous data even in the South Asia. So there are other factors which are contributing. If you look at elevated BMI in Pakistan, it's a little more than 1. So obesity is contributing more to ischemic heart disease compared, but again, in the other countries, it's like closer to approaching 1. If you look at air pollution, again, I guess men work more outside in these countries, so more of a contributor than in women. So physical inactivity showed most pronounced sex difference in ischemic heart mortality and affecting more women than men. And the ratios ranged from 5.81 in Bangladesh to 1.07 in Bhutan. So again, as we talked about earlier, global consumption of all healthy foods is suboptimal in South Asia, where men generally have a less healthy diet. In Pakistan, the dietary gap between men and women is relatively small. And in Pakistan, women consume 18% or less of healthy foods and nutrition. So they play an important role in ischemic heart disease outcomes in Pakistani women. So key points from this, that mortality in patients with ischemic heart disease has substantially increased across South Asian countries. And, when you look at the upstream risk factors, dietary contributors and metabolic are major drivers of excess ischemic heart disease mortality. And the reason we're talking about is that you don't just have metabolic disease, you're obese, you're hypertensive, you have diabetes, and high systolic blood pressure, low intake of vegetables, and these underscore the need for targeted interventions to reduce these sex disparities. So this is a study from our institute when they looked at young women with MI, and you can see hypertension and diabetes, even though the numbers are small in less than 40 years, hypertension and diabetes were the most common risk factors. And we can see in South Asia, the control of hypertension is very poor. If you look at the control, if you actually look at 130 by 80, is in the single digits in Pakistan. So now we shift gears and we talk about what is contributing to these excess risk enhancers in women. And we can, this is relatively gaining more and more popularity in the past 5 to 6 years when they're looking at females specific risk enhancers across the lifespan. And the life of a woman when she reaches childbearing age, because now it has been shown that even as small for gestational infants, they are also at risk of developing cardiometabolic disorders later in life. Younger women experiencing early menarche, the epidemic of polycystic ovarian syndrome, use of certain high estrogen OCPs, premature menopause. This is all contributing to developing ASCVD in midlife. And now we are increasingly recognizing gestational diabetes, preeclampsia, preterm birth, gestational hypertension, multiple miscarriages, and women are choosing to have children later in life, IVF, using fertility drugs. These are being increasingly recognized as risk enhancers for women. Menopause also once because of the declining estrogen activation of the renin-angiotensin aldosterone system is placing them at risk of having CVD. And so the care of a woman starts at, the care of a, I think to develop healthy nations is the maternal health, which has to be really focused on so that babies are produced who are healthy. They have a lower, there are no adverse pregnancy outcomes, the nutrition of the mother, dietary counseling, and these lead to younger, healthy women who have a lower risk of developing this cardiometabolic conditions in pregnancy and eventually producing healthy fetus. So it's a lifestyle. And when we look at this, if you can see, like, in the South Asian, there's a higher prevalence of hypertensive disorders of pregnancy. And similarly for gestational diabetes as well. Again, higher prevalence in this region. So, pregnancy is kind of a stress test. So I think if you call to action, this is the time when you can actually pick up women, and most of the for have developing an adverse outcome from cardiovascular point of view later in life, because pregnancy is a stress test, and most of these women who develop gestational hypertension and gestational diabetes, they are missed. They stop going to the doctor, and they usually present either with an event or full-blown diabetes or full-blown hypertension, stroke 10 years later. So this is a window where American College of Cardiology is working on identifying postpartum hypertension clinics and developing cardio-obstetrics as a subspecialty, recognizing and picking up these women early, because the heart of a woman is unique. And it's not only atherosclerotic CVD, as we talked about INOCA and MANOCA, they also have adverse outcomes long term. So putting it all together, because these adverse pregnancy outcomes, namely preeclampsia, hypertension, gestational diabetes, SGA, preterm birth, and no, often these are overlooked, preterm birth, yes, the child was born early, yes, the child was small for gestation. How many of us actually counsel our women patients, you have a higher risk of having CVD, or how many of us actually end up seeing these patients who develop gestational diabetes? We mostly see them as cardiologists when they've already had an event. So, or we don't see patients with preeclampsia. They're only when, we have combined teams who see these patients. But most of the time, when I was in practice in the US, we hardly saw any patients who had, preeclampsia. We usually saw them either when they had a stroke or they had a heart attack. So, or they have heart failure. So this is a window where it can actually make a difference in the global burden of CVD in women. So there should be multi-level strategies to decrease the incidence and improve the outcome of CVD in women. Health-focused policy focusing on healthier communities, healthier diets, walking in parks, promoting community awareness, health system integration with telehealth, and obviously including women in clinical trials, including women and partnering with other collaborators in our OBGYNs, endocrinologists, and developing a team-based model of care. Thank you.
Okay, thank you, Drs. Oscar, for comprehensive review of global cardiovascular disease burden in a woman. We think there is a sex disparity globally and also in the Asian population. So any comment or question from our panel? So based on your slide in Pakistan, it seems that women have higher cardiovascular disease because of the poor blood pressure control and poor diet control. I think so. Any strategy nationally to balance this result?
I think, you made an excellent point. Yeah, population control, now we are increasing awareness for contraception. And so because the woman then, she's the last person who actually takes care of herself. So, the government is working on it and actually developing collaboration between cardiologists and public health expert and OB/GYN, so we can work as a team. And actually, we have started, in the government, with the public system, we have 2 programs going, one focusing on cardiometabolic disorders as a whole, and with the OB/GYN. So picking up these women who develop preeclampsia, gestational diabetes. So we don't want to miss that window. So we are developing collaboratory programs with them now.
Okay, thank you, Matt. Thank you very much. Okay, if no more question or comment, I think we have completed today 6 excellent talk from our speaker. So at the end of this symposium, I will, on behalf of APSC, I will thank you all of you to participation and contribution to the APSC webinar education. I think through this platform, we can share the updated knowledge and share the clinical experience and work together to promote the cardiovascular disease reduction in the Asia population. Thank you all of you. And last, I will invite Professor Junli Lin to give our some closing remark.
I'm not supposed to give the closing remark, since our second co-chair is busy in more hospital event, and I would say that this is a very attractive webinar because covering a lot of fields in atherosclerotic cardiovascular disease prevention and also the outcome modification. And pretty much impressed by the talk that talking about the risk, how to control the risk by blood pressure and also by the lifestyle modification, and also by the especially important the obesity control. Obesity control seems to be the common problem around the whole world, especially even worse in Asia. It seems that because of the booming of the economic status, it seems in Asia period from East Asia, Southeast Asia to South Asia and also West Asia, we have the same problem, obesity. We are so glad to know that we have a drug that we can really control the obesity and improve its outcome. That's not easy. So we also noticed that the serious problem in women cardiovascular disease in Asia Pacific area, particularly in the South Asia and also the West Asia. Actually, the problem actually going on also with the East and Southeast Asia. So, and women's cardiovascular disease problem need us to focus more on it because we don't really know how different it is, and we don't have too much information or data to say what we are really want to know, how to control the problem, the female cardiovascular disease ever since their pregnancy period. So I think that something is still going on. We will more much on it. And thank you for everybody contributing to this very high intensity web conference for every one of us to know about the prevention and about the cardiovascular disease in the near future. And thank you for all your contribution. Thank you. Okay.
Thank you.
Thank you so much. Thank you everybody.
Okay.
Bye-bye.
Okay, we close the section. Thank you. Bye.
Thank you very much.
Yes.